now we will shift to next speaker, Professor Kakondo. Please start sharing your screen.
Thank you, Same. Thank you, John, for inviting me here. It's really a pleasure to be here in this distinguished symposium with so many titans of spine surgery. Are you hearing me okay?
Yes, yes.
Great. I'm going to optimize my screen for video sharing. And so I know the title of this symposium is Revolution in Spine Surgery. I'm here to discuss and to talk about endoscopic spine surgery. That's really an evolution to a revolution, not only a limited time where we do a great change, but it's been like, I think this more than 30 years of evolution in endoscopic spine surgery, and we will try in the next minutes to cover that history. First of all, I don't have any financial disclosures regarding this topic. So the first things that you have to know is that endoscopic spine surgery is not really a new technique. Started in the early 90s as a way to take advantage of a 1976 approach described by Cambing. You know, that's the really famous Cambing's triangle. And the idea of endoscopic spine surgery, the first generation of endoscopic spine surgery, was to take advantage of that anatomical window to access the foraminal and intracanal disc herniations. But the limits in the technical skills of the surgeons and in the technological advances, there were really high. So the only thing that the surgeons in the early 90s can do is to do what they called the iceberg technique. So I don't know, you can see my pointer here, yeah? So they will go into the center of the disc and take out the center of the disc, and they expected to lower the disc herniation by lowering the disc pressure. So that, of course, it was a really rudimentary technique, and the only indication that they have is that to treat foraminal and intracanal pathology using the foramen as an anatomical window. So what happened is that there were several limitations and contraindications to the transforaminal access. For example, if you're thinking about using the foramen as an anatomical window, if you had a severe foramen stenosis, you with the first generation of transforaminal access, you weren't able to get into the pathology. I mean, you were risking to damage the exiting nerve root. And the same thing happened with the migrations. If you have a hernia that was with a high migration, I mean, like caudal migration hiding behind the pedicle, or maybe a cranial migration, like going into the axilla of the exiting nerve root, it was really hard to access it with a transforaminal access. So this first generation of transforaminal access was really limited to the disc pathology, and to the disc pathology that was in line with the disc space. We don't have to forget that until this point, the endoscopic surgery was a needle-guided surgery. You put the needle, then you put the dilator and the working sheet, and you put the endoscope right in the place where the needle was, and that's all. You can go a little further, a little backward, but that the direction of your endoscope was limited by the needle trajectory. So the thing is that there's a series of complications with this first generation transforaminal access that were related to the damage or maybe mobilization of the dorsal root ganglion. The first reports talks about a 36% of possibility dysesthesia. You know, this is a really annoying symptom for the patient and for the treating physician, and really obscured the results of the discectomy. There was also a great deal of hernia recurrence because the amount of disc that you took out was not good enough with this iceberg technique, and the hernia remainings was really a problem too, because if there was a loose fragment in the canal and you just accessed the main fragment, there's a risk of leaving a fragment behind. So what happened is that a lot of technological advances started to grow, to appear. Kerrison punches, trifines, drills, endoscopic drills that mimicked the armamentarium we have in open surgery in endoscopic surgery. And these technological advances were followed by some degree of expertise and technical advances in the endoscopic spine surgeons. We were able to shift from an iceberg technique and going deep into the disc, the so-called the in-out technique, to the out-in technique, where we go from the outside of the disc, just searching the extruded fragment and releasing the nerve root from the transforaminal axis. With the help of drills, we were able to drill the anatomical boundaries of the foramen and widen the foramen to make a safer access for these herniations. The thing is that if you look at the evidence, that kind of improvements expanded the indications, but they didn't reduce so much the complications that we were talking about. I think that, and this is a personal belief, I think that the game changer was the presentation in the 2006 of the interlaminar approach. It's funny that this approach that uses the same anatomical landmarks that we use in open surgery were groundbreaking in endoscopic surgery. So the thing that Rutten and Comp and Godolias did is that they used the same equipment that was used to do transforaminal access to do interlaminar access. So what you have here is the basic interlaminar access to access this herniation at L5S1. This is a voluminous disc herniation, and our idea is to go with the endoscope through the interlaminar window, trying not to drill or alter the bone tissues, but only opening the flavum ligament, like you see here, identifying the nerve tissues, like you see here, and then unroofing the lateral recess where the nerve axilla is, the nerve shoulder is. So what you are seeing here is this is a really nice maneuver of nerve root relaxation with the working sheet that allow us to go into the disc space by mobilizing the nerve root. So we do an annulotomy. We use our hook to release the hernia, and then we took out the hernia. It's amazing how big these fragments can be. It's usually like this or bigger. And if we are not happy with the decompression of taking out the fragment alone, we can go and take out an osteophyte like this with a chisel, or you can drill it with a diamond burr. It's really safe to drill with the protection of the working sheet and release the nerve root like this. This is the final view. You can mobilize freely the nerve root. You can watch the disc space, and that's the flagellum ligament window, and this is the hernia that we extracted. So this is the basic of interlaminar approach to the lumbar spine. And that's what's really groundbreaking, because it allowed to treat a number of pathology other than these herniations, and overcome some anatomical limits, like high iliac crest to go into the L5S1 space, and some revisions and papers show that actually the recurrence of the herniation was less when you use interlaminar approach. But the thing is that when even with the advantages of interlaminar approach, you had like two compartments that were outside the reaches of interlaminar approach. That was foraminal and extraforaminal zone. So the thing that happened is really interesting, because interlaminar approach demands more freedom of movement and maybe more skill to the endoscopic surgeon. When you are doing an interlaminar approach, you're no longer limited to the disc space. You have to be able to navigate through the anatomy with your hands, with the endoscope. And the thing that happened is that the surgeons started to do the same thing that they do in the interlaminar approach with the transforaminal approach. So they copied the maneuvers that they were using in interlaminar approach into transforaminal approach, and the result was marvelous, because we were able to treat pathologies that we weren't before. This nice lady with the R4 nerve root pain, just going into the foot, and look at this listhesis compressing the L5 nerve root, with mainly because of the osteophyte, and it's a stable case. The dynamic X-rays didn't show any movement. So our strategy here was to go first into a safe zone, that's the SAP of L5, and then navigate under endoscopic visualization until we reach the pedicle, and then the L5 osteophyte. So this is only possible because we have the ability to navigate and the freedom of movement that we learned in the interlaminar approach. So when we get to the osteophyte, we will remove it, access to the disc space, and then remove the L4 osteophyte, and then release the soft tissue that is compressing the L4 nerve root. So look at this. This is the axis. I think this is a really nice way to approach a troublesome foramen. We go into the SAP. We used to go directly into the disc space, and that was a really dangerous for the exiting nerve root, because what we observe is that sometimes we damage the exiting nerve root with the puncture needle. So from, I think, 3 years from now, we are going into SAP and then navigating from the SAP to the disc space under endoscopic visualization and checking out that the exiting nerve root isn't in the way of the endoscope. And the percentage of postoperative dysesthesia has lowered a lot. I think we have like 2 years postoperative dysesthesia free since we started doing this approach. And the idea is to navigate under endoscopic visualization, like I said before. So here's the first view. You had the SAP. We are going to navigate to the foramen. And this is, I think this is a nice view. You have like the L5 SAP here, the nerve root in close proximity with the L5 osteophyte going from the end plate that we are aiming to remove. So we're going to start like protecting the nerve root with the working sheet and drilling the center of the osteophyte. The idea is to cavitate the osteophyte and then fracture it from the outside to the inside, and then remove the osteophyte with a Carrison punch, protecting the nerve root in every step. We are going to drill here from lateral to medial to make sure that the whole extent of the osteophyte of L5 is removed. That's a diamond board. This is an eye combination of technique and technology together. And you're going to see that here the disc space is becoming visible. That wide line in there is the disc space. And now that we have achieved the level of L4 due to the listhesis, we are going to go for the L4 osteophyte that's compressing the L4 nerve root. So we are going to drill the L4 osteophyte too. And once we had removed the L4 osteophyte, the only thing we have left to do is to remove the compressing soft tissue. We are going to do this with a combination of coagulation and Carrison punches and love punches. This is a way to shrink the soft tissue and then remove it with the Carrison punch. And to finish, we will going to dissect a little of nerve root to make sure that there's no more soft tissue compression it. So here's the final view without osteophytes and without soft tissue compressing the nerve root. It's really nice to see the postoperative CT scan, especially in the sagittal plane, where you can see the restitute foramen. Here we had this osteophytes compressing the nerve root, and here there's an absence of compression that reflects in the patient's evolution. Here's the 3D reconstruction. So these lessons learned from the intralaminar axis expanded the indications of the transforaminal axis. We started to deal with a complex pathology like severe foraminal stenosis, listhesis, some recurrence from neurosurgery. You know, it's a nice strategy to, if you have a patient that had an open surgery from the midline, if you can solve the problem from the transforaminal axis, you avoid the whole fibrosis problem, and it's really satisfying for the patient and for the physician. of course, we started to challenge ourselves and treat another kind of complications. Here is a case of a patient that was operated through open surgery. She had a cage between L4 and L5, and the cage migrated and started to compress the exiting railroad. So what we did was an endoscopic approach that tried to anchor the needle and the working sheet into the remains of the SAP. Here you can see the axis, and the idea was the same, to navigate from that safe zone to the foramen and identified the nerve root, the cage, and the remnants of the L5 SAP. And look at this. This is the same maneuver that we use in the interlaminar approach. This rotating maneuver with the working sheet allow us to mobilize the exiting nerve root and access the place where the cage was. And here's the cage exposure. That's a peak cage. We are assessing mobility, and the cage wasn't mobile, so we had to remove some of the osteophytes covering the cage, and to gain some direct access to the cage. And then we started drilling the cage to lower the volume of the cage until we reached like the metallic landmarks of the cage. The good thing is that when you diminish the volume of the cage and you unrotate the working sheet, you can see that the nerve root rests without compression of the cage. So this is the before and after photo of this patient. So this is an example how interlaminar technique affected and improved our transforaminal technique. Obviously, our improvement in techniques and technology didn't just ended with transforaminal access. We started to do some, I think that expanded indications for interlaminar access, just as the Juxtafacet cyst. I like this term because it's puts together like synovial cyst, ligamentum flavum cyst, and ganglion cyst. And the discussion about this kind of cyst, it was that there's a wide variety of treatment available, and we started to see in the publications that fusion is only necessary when you have a previous instability. If you can go and just quietly and softly take out the cyst and maybe drill the facet in the exact attachment point of the cyst, the results are really good, and you don't have a posterior instability. And that's why endoscopic surgery it's really a good option from these patients. Here's a patient that had a synovial cyst arising from the L5S1 segment. You can see here how it compresses the S1 nerve root. And the right side, we have our standard interlaminar approach here with all the same technique that we use for a disc herniation. With only one difference. We in cyst, we like to expose the cyst from cranial to caudal to see the interface between the cyst and dura mater and nervous tissues. So we had here to widen the L5S1 interlaminar window. Here we have the final window, the one we widen, and this is the opening of the ligamentum flavum. We do it really, really carefully with the scissors and the sectors, and then we start to see the attachment of the cyst to the dura. We are removing the ligamentum flavum cranial to the cyst, and we start to see how it's really attached even to the ligamentum flavum. And this is a maneuver I like so much. This is the mimic of the bimanual maneuver of dissection that we do in open surgery, but in endoscopic surgery. We have here a two-handed dissection maneuver. I don't know if you can see it in the video, but what I'm doing here is with my left hand, I am mobilizing my working sheet and using it as a dissector to move away the cyst and be able to coagulate the adherences of the dura and the cyst. Here we are coagulating and then dissecting really softly to avoid damage to the nervous tissues. We continue this process of coagulating and then removing. And here you can see how we coagulate the cyst and dissect. And there is something really interesting here. You know, when we did open surgery, opening the cyst resulted in incomplete remotion because the cyst loses some shape. Here in endoscopic surgery, you have a continuous output of fluid, of water into the cyst. So even when you remove it piecemeal and empty the cyst, the capsule is still it's still full. So there's no inconvenience on emptying the cyst. It's really favorable because you can dissect it more easily. So here we are dissecting the cyst from the S1 nerve root and starting to reach the end of the surgery. That scissor technique has to be really delicate to avoid damage to the neurostructures. So here we are taking out the final part of the cyst, just peeling out the nerve root under endoscopic visualization, and then taking out with kerosene punches. And then we check with the X-ray if you are really in the caudal limit of the cyst. And this is the final revision. You have the S1 nerve root totally free. You can mobilize it without any attachments, without any problems. And the thing is that when we do some control, some MRI control postoperative, we see the absence of the cyst, and not only the absence of the cyst, but the absence of damage to muscle and ligaments. The same muscle that the patient had before is the same that she had after the surgery. Obviously, when you look at the functional, the dynamics X-ray, 6 months postoperative, there's no instability. So what about doing some changes to the extraforaminal and foraminal access to the L5-S1 disc space? I told you before that this is a really troublesome space for us endoscopic spine surgeons because the access is not always simple. You had to avoid the high iliac crest. You had to avoid the sacrum promontory, and you had to avoid the transverse process of L5. And there's a new kind of approach, a relatively new kind of approach that is a contralateral interlaminar that allows us to treat lateral recess and foraminal pathology from the other side while using the same techniques that we learned in interlaminar approach. So here's a patient that had a combined pathology. He had a facet cyst and foraminal stenosis, 68 years old, really active, a marathon runner. He had an open discectomy 14 years ago that put a lot of scar tissue, even in the L5S1 disc space. And here's the MRI. You can see the foraminal stenosis and the synovial cyst. So what we plan here is to access that space from the contralateral side to be able to treat both diseases at once with one approach. So this is the occluded foramen in the CT scan, and our approach was this contralateral interlaminar approach. We were aiming to first identify this angle, then go dissecting the ligamentum flavum and releasing the ligamentum flavum contralaterally, and finally accessing the attachment of the cyst into the SAP. Yeah, the idea was to drill the exact amount of SAP necessary to prevent cyst recurrence, and then perform an adjusted foraminoplasty from the inside to release the L5 right nerve root. So this is the approach. We go a little further lateral than the usual interlaminar approach, go from lateral to medial, and then start to drill the ventral cortical surface of the lamina of L5. We release
Excuse me, Doc, we have to wrap it up, okay, in a minute or so.
Oh, okay. Just going to the final conclusion. You have the possibility of perform cervical spine surgery if you translate your lesson learned to the cervical spine, and even if you have complications in the lumbar spine, if you refine your technique, you can go and perform some technical nuances like this one. This is I think that it's necessary only in cases when you have an open bridge. Here you can see the incidental durotomy, and you can perform. It's possible to perform. Let me see here. You can perform a suture of your incidental durotomy with an endoscopic technique. I mean, it's not for newcomers, but it's possible, and you can close your dural incidental durotomy from the outside to the inside with a suture. Okay, so the take-home message is that the endoscopic surgery that you heard like 20, 30 years before is not the same that we had today. It's evolving continuously. There's different generations of endoscopic techniques coexisting today. You can go to a center and maybe see still using methylene blue and doing transforaminal only. And you can go to another center and see more state-of-the-art endoscopic surgery. And the idea is that there's a limit of what you can do with technology, and you can buy the top technology. But that I think that the first and the most important limited is the ability of the surgeon that must be trained. This is the end. The idea is that revolutions in everything, not only in spine surgery, can be done with time or with blood, with mistakes, and we have to choose time. We have to take our own time to make that revolution happen. And that's the end. This is my city. This is Rosario, the birthplace of Lionel Messi and Che Guevara. And you're all invited if I can help you with anything that you want in endoscopic surgery. Thank you for the invite again.
Okay, Facundo, thank you very much. I hate to be in a rush, but we have another conference going on. Thank you very much, Facundo, and thanks